Very warm good afternoon, everyone. I'm Dr. Sandeep Sapkota, NBMS subspecialty resident on surgical oncology in thoracic stream in BPKMCH, and I'll be talking about the evolution of thoracic surgery at BPKMCH. Before starting, I'd like to declare that I do not have any conflict of interest, and there is no financial or material support for this presentation. If there is any error, these are mine alone. So I'd like to start with the Sanskrit sloka. This is the anchor, philosophical anchor of my talk today, which states like Saridayam Sabhigyanam Bhadram Bhadram Vidyatam, which means shared hearts, that is unity, shared knowledge, that is fraternity, and shared work, that is service. These all collaboratively give the best possible outcome. So this is where this evolution comes from, the shared hearts, knowledge, and work. And discussion of evolution matters because looking back gives an idea to look forward. If we talk about BPKMCH, it's the place that we're standing today, was established in 1992 as Nepal's first dedicated cancer hospital with serving more than 7 million people from central and western Nepal and northern part of India. And now we are doing annually more than 3,500 surgeries. And also if we look at the global burden, the lung cancer has been the most common cancer worldwide since 1980s, late 1980s, when she started registering the cancer cases. And ever since, the lung cancer has been on the top for 4th decade. So a thoracic department is must if we want to establish a cancer center. So in Nepal, also, if we look at the relevant burden, according to the National Hospital-Based Cancer Registry, approximately 49.3% of lung cancer cases were diagnosed as BPKMCH as per the registry. And also because of the high incidence of lung cancer, the incidence has been ever rising. And due to high incidence of TB and its pulmonary sequelae also, we were forced to do the surgeries in the earlier days. And the necessities forced us for innovation, and dedication forced for the progression. Talking about the evolution from 1992 to 2006, it was the earliest era for us. 1992 to 1999 was what I call a turtle stage. A turtle because it was slow to start, a turtle because it was sign of something auspicious. And then in 1999, there was establishment of first inpatient department. In 2001, the first major lung resection was done. In 2006, thoracic oncosurgery unit was established, while after 3 years, a dedicated thoracic ward was established. I'll be presenting data from 2007 onwards because data from 2001 to 6 are largely missing. It's the national problem, as we already talked in our previous session also. So from 2007 to onwards, the evolution is further divided into foundational years. Then we slowly transitioned ourselves into minimal invasive surgery. And then modern thoracic surgery, that is 2016 to present. I'll be dissecting each one slowly. The foundation era was 2007 to 10 when we used to do the open conventional thoracotomy era. This was our old OT setup. I'm sure sir in front of me recognized this pretty well. So it was characterized by limited ICU support, high post-operative morbidity, and lack of advanced stapling devices at that time. But still, in 2009, we did Nepal's first minimally invasive esophageectomy, which was a landmark achievement at that time at BPKMCH. And then in expansion era, the minimal invasive expansion was started. We increased the VATS procedure, better anesthesia and perioperative care were established, and we were seeing the growing thoracic surgical volume. So these were some of the procedures that were introduced slowly in our routine practice, that is VATS pulmonary section, VATS biopsy, VATS decortication, midason surgeries, pleural surgeries as well, and sympathectomy, thymectomy, etc. So in 2011, in expansion era, we did first VATS thymectomy in Nepal, which was also another milestone. And the development of MDT team was another achievement for us during those period in collaboration with medical oncology, rad-onc, and pulmonary medicine, radiology, pathology, and ICU anesthesia team, which was also started in our expansion era. So if we talk about the numbers, from 2007 to 2024, we have seen the 9-fold increase in major surgery numbers. In pleural disease as well, the numbers have significantly increased, and we have also transitioned largely from open to MIS. In pulmonary disease as well, now we are slowly transitioning much towards the MIS. And the esophagus and GEJ series was recently published, and we had the highest number of esophageal surgery data, that is 547 in number, and slowly in 2024 and 25 we are doing 80% of the cases via MIS. And in case of mediastinal disease, the MIS or minimal invasive approach has took over the open approach by a huge margin. So this is our modern OT setup. In modern era, we are doing advanced VAT surgery, uniportal thoracic surgery, which is a cutting edge even by the global standard, precision-based thoracic oncology, and which is the part of personalized cancer care in recent era, enhanced perioperative care, better ICU support, and ERAS principle are being applied now in our patient for the faster recovery. So as I mentioned, minimal invasive esophagectomy increased to nearly 80% of the esophageal resection in 2020. So we are also doing the precision based lung resection. We are using the 3D simulation to localize the solid pulmonary nodule and resecting just the segment that is diseased, sparing the normal lung. In 2025, we did the sub-xiphoid uniportal non-intubated thymectomy in a patient of myasthenia gravis, and which was a landmark achievement and first in Nepal at that time. And in same year, after 3 months, we did non-intubated VATS pulmonary sublobar resection in IV, total IVA and local anesthesia. So this was the earlier preliminary open incision while doing the esophagus, even for the lung resection as well, starting from the 25 to 30 centimeter long incisions to now to the MIS phase. The incisions are lesser, around 4 centimeter in abdomen and some few ports in 3 ports in chest. So this largely benefit for the better recovery of the patient and decrease the morbidity as well. If we talk about the achievements in nutshell, so these are already been discussed. And apart from that, we have significantly improved in our academics. In 2020 and 21, the one-year fellowship in thoracic surgery was started, but it was later stopped because MEC approached for NBMS subspecialty residency program, under which I am also there, and 2 passed out thoracic oncosurgeons are already in market. And regular department presentation is there, which is regularly uploaded in our YouTube account as well. And BPKMCH, when I was doing MS residency, was an outstanding experience for me. That's why I chose this center for my subspecialty MCH residency as well. I'm sure it has been the best place for everyone to learn for residents in every streams. And if we talk about publications and research, more than 50 publications has already been published in last 10 years from our department alone. So, but still that is not all for us. We are hoping to get the possibilities of robotic thoracic surgery in near future, AI-guided imaging for small solid pulmonary nodules, expansion of non-intubated surgery, and the thoracic transplantation possibilities, which means the auto-transplantation, meaning transplanting a lobe from one hemithorax to another hemithorax. So before ending, I'd like to acknowledge the few pioneers who came before us, who set a pathway for us, and I should not end the presentation without mentioning them. Is Dr. G.P. Sharma, who did the first esophagectomy in Nepal in 1980s. Professor C.L. Vattajan, who have quite a few number of esophagus and GEJ tumor, who also standardized the esophageal CS surgery at that time. Professor Moez Khakurel, who started the minimal invasive surgeries in Nepal, of course, set a landmark for us to start the minimal invasive surgeries. Professor Prakash Saimi, I should not forget him if we talk about the thoracic surgery in IM. And Professor Sunil Sharma also, he standardized the radical surgery for esophagus in those days. And then Dr. Bhagan Koirala helped to establish the single unit of cardiac and thoracic surgery. And now Dr. Ranjan Sapkota is handling and heighten the legacy at IM for thoracic surgery. And Professor Sampurna Mantulada also, he has done an outstanding work in thoracic surgery evolution over the time. So if we look at the pioneers of at BPKMCH, Professor Bhaktaman Shrestha, who have done the who was one of the pioneers at BPKMCH for esophageal surgery, and then Binay Thakur, Dr. Binay Thakur, who steered the evolution over the time Dr. Nirmal Samichani, who also did quite few number of esophagectomies and lung resection at the initial days. These are the pioneers at the BPKMCH, and if I say the steerer of this evolution, I should mention my mentor, Dr. Binay Thakur, and Mukti Devkota, who worked in this institution for quite some time over the years. And this is the thoracic team at present. I'll keep the introduction aside. And also my sincere gratitude for anesthesia and ICU teams, the mentors and faculties from international hospitals, especially from China, nursing staffs, and all the staffs from the hospital as well as the hospital administration. So from basic open procedure to innovative minimal invasive surgery, we have come a long way, seeing ourselves grow 9 times from the open initial days. And 80% of esophagectomy is being accomplished now. We are even seeing the 20 to 25% resectability for lung cancer, which is on par with the global standards. And it has been first center for 6 major thoracic milestones. So we are trying to upgrade ourselves day by day, year by year. So I'd like to end my presentation as I started with the sloka. The 3 words, unity, fraternity, and service, is the slogan of the Nepal Medical Association. These 3 words helped us to get evolved over the years, and these 3 words will help our fraternity to get evolved over the years. Thank you.
Thank you, Dr. Sandeep. If you have any questions?
म नेपालमै भन्छु अलिकति हाम्रो BPKMCH को बारेमा सबैलाई थाहा छ के र धेरै अब अडियन्सहरु चाहिँ एकदम कम हुनुभयो हामीले यो इन्स्टिट्युसनलाई यद्यपि म थोरै वर्ष भयो झन्डै 12 वर्ष भयो यो संस्था छोडेको र अहिले मैले कम्पेयर गर्छु when I was attached to this center and now out of this center, my junior colleagues, especially Dr. Binay Thakur, he is a leading thoracic surgeon. Although he was not interested to take this profession, he was very much interested to join the GI surgeon, but I forced him to start his career in thoracic surgery. If you go back 30-35 years back, I still remember I put strong force on him. He rejected, but ultimately he accepted my request, and he has established, like Dr. Binay Thakur, he is a synonym of thoracic oncosurgeon in this country. Under his guidance, Dr. Sapkota and other fellows are learning a lot see different varieties of surgery. Not only the thoracic surgery, even cardiac, CA cardia.
Yes.
Let's say upper GI surgery and lower GI surgery also. And Dr. Sapkota, if anyone कोही पनि आउनु भरे छन् मेरो इच्छा के छ भने म्यानेजमेन्टको डाक्टर उमेश र अहिले फेरि स्कार्सिटी के भइराछ भने सरकारले सायद रिटायरमेन्ट चाहिँ 55 वर्षको धेरै हल्ला चलाइएको छ त्यो भने एउटा लट अफ सर्जन्स लट अफ अरु डाक्टरहरु पनि क्यान्सर अस्पतालबाट बिदा हुन बाध्य पारिएको छ बाध्य पारिन्छ होला यदि 55 को आयो भने फेरि खडेरी पर्न सक्ने सम्भावना धेरै छ अब डाक्टर सबभन्दा नजिक त हामी मध्येमा हाम्रो डाक्टर सुदीप केसी हुनुहुन्छ जो मनोहर प्रधानसँग एकदम क्लोज कन्ट्याक्टमा हुनुहुन्छ र उहाँहरुले रिथिंक गर्न पर्ला अलिकति सोच्न पर्ला कि भनेर किनभने उहाँको पनि ठूलो रोल छ अहिले मिनिस्ट्रीमा एडभाइजर हुनुहुन्छ र अहिले चट्टै हाम्रो मेरो जुनियर कलिग इभेन डाक्टर निर्मल डाक्टरको त अहिले टाइम नै छ डाक्टर बिनय चाहिँ डाक्टर देजहरु चाहिँ अब बाध्य भएर छोड्नु पर्यो भने त उहाँले इमिडिएटली भोलि पर नै छोड्नु पर्ने हुन्छ अनि त्यो कसरी फुलफिल गर्ने भन्ने कुरा चाहिँ म्यानेजमेन्टले अहिले सोच्न पर्ने हो यद्यपि बोर्ड बनेको छैन नयाँ बोर्ड आयो भने हाम्रो नि अलिअलि इन्फ्लुएन्स होला बोर्डबाट नयाँ केही थप कन्ट्याक्टमा गर्ने कि के गर्ने त्यो आइडियाहरु हामीले नि शेयर गरौँला मैले पनि सकेको गरौँला मलाई चिन्ता त्यही विषयको छ अब डाक्टर बिनयको कन्टेम्पररी जानुभयो भनेदेखि सबैमा रेडियोलोजी रेडियोथेरापी सबै डिपार्टमेन्टमा क्राइसिस नै हुनेवाला छ त्यसले गर्दाखेरि डाक्टर निर्मल हुनुहुन्छ के अहिले अलिकति सोच्न पर्ला एज अ चेयरम्यान पहिला चेयरम्यान हुनुहुन्थ्यो अब हामी अलिकति फोर्स गर्नुपर्छ हामीले यद्यपि निर्णय भइहाल्यो भने पनि केही वेहरु सोच्न पर्ला त्यो एउटा चिन्ताको विषय छ। साँच्चै नै हाम्रो यो क्यान्सर अस्पतालमा थुप्रै कुराहरू सिक्ने ठाउँहरू छन् र फेलोहरूले अब त हुँदा सिट पनि बढाइदिए हुन्थ्यो भन्ने हो मेरो इच्छा त सबै विषयमा। अनफर्चुनेटली द युनिट वेयर आई वाज एकदम एट्याच थिएँ जिआई सर्जरी चाहिँ जिआई सर्जरी अलिकति सोचेको जस्तो मैले पाउन सकेन, किनभने फेलोसिप नै हामीले लिन सकिरहेका छैनौँ। त्यो र गाइनेमा आइसक्यो, युरोलोजीमा आइसक्यो र थोरासिकमा आयो, अरू विधामा चाहिँ नि आउन सकेको छैन। अब डाक्टर उमेश नभएको हुनाले अलि चित्त दुखेको छ मलाई। डाक्टर वी मस्ट ह्याभ कम, किन आउनु भएन डाक्टर, हामीले मैले आशा गरेको थिएँ। यो हजुर अर्को सेसनमा उहाँको त नाम यहीँ थियो नि यही सेसनमा। र हामी सबै मिलेर बीपीकेएमसीमा एट्याच हुनुभएको अथवा नभएकोहरूले पनि यो संस्थालाई ग्रो गर्न सबैको रोल रहला। हामी धेरै सिनियर छौँ, डाक्टर सेणाई पनि हुनुहुन्छ, प्रोफेसर हुनुहुन्छ, डाक्टर सुदीप यो संस्थामा एट्याच नभए पनि अरू कलिगहरू पनि हुनुहुन्छ। यो संस्थालाई बचाउन सक्यो भने भोलि अब दुर्भाग्यवश मेरै साथी मेरो कन्टेम्पोरेरी डाक्टर प्रकाश न्युपाने हि पास अवे बिकज अफ कोलान्जियो कार्सिनोमा, यद्यपि त्यो चाहिँ वर्स्ट डिजिज थियो र हामी पनि त्यसैको भोलि हामीलाई नि के थाहा भोलि के हुनसक्छ। हामीले यही बीपीकेएमसीएचमा उपचार गर्न पाउने व्यवस्थाहरू गर्न सक्यौँ भने कन्ट्रीको लागि ठुलो गुण हुनेछ। एआई भन्नुभन्दा पनि अहिले हामीलाई त म्यानुअल नै गरौँ बरु। हामीले जे सिकेको थियौँ हिजो पनि मैले कुरा गरेको थिएँ, बिग सर्जन मेक्स बिग इन्सिजन भने जस्तै अझ पनि मिनिमम त छ र पनि हामीलाई बाँच्न पर्यो। कस्मेटिक आफ्नै ठाउँमा छ, अलिअलि सेफ्टी आफ्नै छ, तर बाँच्न त पहिलाको मान्छेहरू पनि वर्षौँ बाँचेको छ, सयौँ वर्ष के अरे क्यान्सर सर्जरी पछि अथवा मेडिकल अङ्कोलोजी बच्चाहरूलाई पनि त लिकिमियाबाट 50-60 वर्ष बाँचेको त थुप्रै छ, निको भएको छ। त्यसले गर्दाखेरि सबैलाई मैले यो अपर्च्युनिटी लिएँ, क्यान्सर अस्पतालका बारेमा सबैले पोजिटिभ हिसाबले लबी गरिदिनु होला भन्ने अनुरोध गर्छु। र मेनी थ्याङ्क्स डाक्टर सापकोटा। हामी सपोर्ट गर्छौँ भोलि क्यान्सर अस्पतालमा कन्टिन्यू गर्नको लागि। आफ्टर फेलोसिप डिग्री अवार्ड गरेपछि पनि आज थोरासिक सर्जनको रूपमा थोरासिक सर्जनलाई मात्रै टिपेर अगाडि बढ्यौँ भने त्यसले सबै कुराहरू गेन गर्छ। त्यस्तै भाइलाई पनि थोरासिकको एकदमै भविष्य छ, केस घट्नेवाला चाहिँ बढ्दो नै छ। त्यसले गर्दा त्यसमा आफ्नो करियर बनाउनु, बीपीकेएमसीको बढी लिडर बन्नु, यो मेरो विश छ। थ्याङ्क यू।
थ्याङ्क यू सर, थ्याङ्क यू सो मच।
Thank you, Bhagwan sir and Dr. Sandeep.